Hi everyone, I recently did a lecture on the ACC-AHA versus ESC guidelines on heart failure management, and I thought of making a video on it. So, bam! ACC-AHA versus ESC guidelines. The focus on this lecture is going to be medications or pharmacological therapies for heart failure management, and I'm going to cover mostly HFrEF or heart failure with reduced ejection fraction, commonly known as systolic heart failure. I want to start off by talking about cardiac biomarkers, which are known as natriuretic peptides, namely BNP and proBNP. And both guidelines do agree that they are useful in establishing the diagnosis and prognosis of heart failure. I do want to emphasize that the negative predictive value is very high, which means if a patient does not have elevations of natriuretic peptides, then chances are that the patient probably does not have heart failure. However, the positive predictive value is lower, which means that if it's elevated, it could be due to any reasons, and there are a number of reasons that can cause elevation of proBNP and BNP, including age, atrial fibrillation, renal failure. That's why the natriuretic peptides should be used to rule out heart failure, but not to establish the diagnosis of heart failure. I also want to mention that proBNP and BNP levels may be low in obese patients. Question machine. So whenever you see this slide, it means that you should put your thinking cap on because I'm going to ask you a question. And the question is, should you trend BNP levels while in the hospital? Should you be checking it every day and make sure that the levels are going down? And should you manage the patient based on the BNP levels? And the answer is that there isn't enough data. We know that BNP and proBNP levels decrease with treatment, and a decline over time correlates with improved clinical outcomes. But should we guide our therapy based on biomarkers? There isn't enough data to inform of a specific guideline. Both guidelines do recommend an EKG to be performed in all patients presenting with heart failure initially. An EKG can provide information on the etiology of heart failure, such as myocardial infarction. It can provide indications for therapy, such as anticoagulation for a patient in atrial fibrillation, pacing for a patient with bradycardia, and CRT if there is a broadened QRS complex. An echocardiogram should be performed for initial evaluation of heart failure, and an echocardiogram provides a lot of information. It tells you the ejection fraction, it tells you if there is any wall motion abnormalities, if there is any valvular dysfunction. But when should you repeat the echocardiogram? So a repeat would be useful in patients who have significant change in their clinical status, if they've received treatment that might affect the cardiac function, or if they are being considered for a device therapy. So heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. And the manifestations of heart failure can be dyspnea, exercise intolerance, fluid retention, pulmonary congestion, and peripheral edema. Since we're going to talk about the terms HFrEF and HFpEF, I do want to explain the terminologies to you. So the American guidelines states that if the ejection fraction is less than 40%, it is classified as heart failure with reduced ejection fraction, or HFrEF. If the ejection fraction is above 50% and the patient has signs and symptoms of heart failure, it is classified as heart failure with preserved ejection fraction. If the ejection fraction is between 41 to 49, it is classified as heart failure with preserved ejection fraction, which is borderline. And if the ejection fraction, which was previously less than 40%, is now greater than 40%, it is classified as HFpEF, which is improved, which means that the patient previously had HFrEF. The European guidelines have the same definition for HFrEF and HFpEF. However, patients with an ejection fraction of 40 to 49% are classified as heart failure with mid-range ejection fraction. So there's a difference in terminologies. Since the guidelines always talk about the stages and the NYHA class, I did want to put the slide out here for those who want to review the stages and the NYHA classes before getting into the guidelines. I do want you to know the level of evidence and classes of recommendations of various guidelines. We will be focusing on the class 1 indications where the benefit is greater than the risk and the treatment is recommended or indicated. And we'll also focus on the class 3 recommendations because it's important to know which treatments or procedures have no benefit and may also be harmful. So let's talk about the pharmacologic treatment for heart failure with reduced ejection fraction. Can you guess which 2 drug classes, with the smiley faces represented on the slide, are indicated in all patients with HFrEF? If you were thinking of ACE, ARB, ARNI, and beta blockers, then you are absolutely correct. We know that ACE inhibitors can reduce morbidity and mortality in patients with symptomatic heart failure with reduced ejection fraction. However, it is also important to keep in mind that ACE inhibitors can prevent symptomatic heart failure in patients with a recent or remote history of MI or ACS and reduce ejection fraction. And in patients with type 2 diabetes, it can reduce the incidence of heart failure. So everybody gets an ACE inhibitor. It is important to keep in mind that dose matters. So even though we start the patients on a low dose initially, we have to increase the dose till we reach the target dose that have been shown to reduce the risk of cardiovascular events in clinical trials. Another thing to keep in mind is that abrupt withdrawal of ACE inhibitors can lead to clinical deterioration and should be avoided. If the patient has intolerance to ACE inhibitors due to cardiorenal limitations, that itself is associated with a poor prognosis. So I just put in some memes over here for some laughs. Angiotensin II type 1 receptor blockers or ARBs are recommended in patients who cannot tolerate an ACE inhibitor, and they are used to reduce morbidity and mortality. It's important to keep in mind that ACE inhibitors and angiotensin II receptor blockers can cause hyperkalemia, so the combination of the two should be under strict supervision and should be done in only those patients who are unable to tolerate an MRA or a mineralocorticoid receptor antagonist. And we're going to talk about MRAs in a little bit. Now, these drugs are cute, but they are dangerous. So we must exercise caution in patients with low systemic blood pressures, increased serum levels of creatinine, bilateral renal artery stenosis, or elevated levels of serum potassium. They are associated with adverse effects such as angioedema and cough, which is due to kinin potentiation. ARBs do not inhibit kinase, so they're associated with a much lower incidence of these side effects. Some patients also complain of rash and taste disturbances. Question time. Which drug was recently approved that acts on the renin-angiotensin system? If you were thinking of an ARNI, then you are correct. The angiotensin receptor neprilysin inhibitor, or ARNI, is a combination of two drugs, an ARB and an inhibitor of neprilysin. Neprilysin is an enzyme that degrades natriuretic peptides, bradykinin, adrenomedulin, and other vasoactive peptides. So it is logical to think that if this enzyme is inhibited, the natriuretic peptides levels would increase. So patients who are on an ARNI will have increased levels of BNP. However, NT-proBNP is not a substrate for neprilysin, so those levels are unaffected. So it's important to be cognizant of which biomarker you're looking at when you go through your patient's labs. The wording of the guidelines differ when talking about ARNI. The ACC-AHA guidelines recommend replacement of the ACE or ARB by an ARNI in patients with symptomatic HFrEF. And the ESC guidelines recommend replacement of an ACE by an ARNI in patients who remain symptomatic despite optimal treatment with an ACE beta blocker and MRA. An ARNI should never be administered with an ACE inhibitor, or even within 36 hours of the last dose of an ACE inhibitor. ARNI should also not be administered to any patient with a history of angioedema. And this is going to be a trick question in your exams where they're going to talk about a patient who had angioedema with an ACE and now are an ARB. Should we replace it with an ARNI? And the answer will be no. And it's going to be a trick question. The use of ARNI is also associated with hypertension and renal insufficiency, just like ACE and ARBs. Beta blockers be like lol. So which 3 beta blockers have been proven to reduce mortality in patients with HFrEF? If you were thinking of bisoprolol, carvedilol, and metoprolol, then you're absolutely correct. Question machine. So we know that beta blockers have negative inotropic effects on the heart. Knowing this fact, should you stop a beta blocker during a heart failure exacerbation? The answer is, it depends. So it's expected that the beta blockers will cause fluid retention, and that's why whenever you start a patient on beta blockers, it is recommended that you also start them on a diuretic to prevent exacerbation of heart failure. The initiation of a beta blocker therapy should be at a low dose, and it should only be done when the volume status of the patient is optimized. Abrupt withdrawal of a beta blocker can cause clinical deterioration, and it should be avoided. Now, if the patient is hospitalized for heart failure and has marked volume overload and low cardiac output, and if they have been recently started on a beta blocker or their dose has been increased, in that case, withholding or reduction in beta blocker therapy is recommended. The adverse effects of beta blockers include bradycardia or heart block, and if that occurs, decreasing the dose of beta blocker is recommended. Beta blockers can also cause hypotension. So if you are administering a beta blocker with an ACE inhibitor, it should be at different times of the day. And we already talked about the fluid retention and the worsening of heart failure. in which case just the intensification of conventional therapy should be done, and you should try to keep the beta blocker on board. Patients also complain of fatigue with a beta blocker, and it's probably the hardest symptom to address. So let's talk about diuretics or the water pill. And both guidelines do recommend the use of loop diuretics in patients who have volume overload. And the aim of diuretic therapy is actually to maintain euvolemia at the lowest achievable dose. Now, patients can be trained to self-adjust that diuretic dose based on signs and symptoms of congestion and based on daily weight measurements. Thiazides have more persistent antihypertensive effects, so they are perfect for your patients with hypertension and mild fluid retention. The most commonly used loop diuretic is furosemide, and bumetanide and torsemide have increased bioavailability. Question machine. So what are reasons for diuretic resistance and how can you overcome them? So patients may become unresponsive to high doses of diuretics if they're taking large amount of salt in their food. So you have to ask them to cut their dietary sodium intake. If they're taking NSAIDs, which can actually block the effects of diuretics, or if they have impairment in renal function or perfusion. And the resistance can generally be overcome by using IV diuretics or a combination of different diuretic class like metolazone with loop diuretics, etc., etc. I found this to be interesting. Diuretics have been shown to prevent heart failure in patients with hypertension. So that's something to keep in mind, and if you're treating someone with hypertension, think of a diuretic and consider it. So let's talk about the aldosterone receptor antagonist or the mineralocorticoid receptor antagonists such as spironolactone and eplerenone. So we know that they block the receptors that bind to aldosterone, and aldosterone promotes absorption of sodium and excretion of potassium, and it also promotes cardiac fibrosis, and this is why they are used in heart failure. RAILS, EPHESIS, and EMPHASIS trials are the landmark trials for MRAs, and I thought of putting them here. Both guidelines do agree that spironolactone or eplerenone should be recommended in all patients who are symptomatic despite treatment with an ACE and beta blocker and have an EF of 35% to reduce mortality and heart failure hospitalizations. The ACC guideline also recommends that any patient who has NYHA class 2 symptoms and a history of a cardiovascular hospitalization or an elevated BNP should be considered for an MRA. So it's more lenient on the guidelines. It also recommends that patients with a history of diabetes mellitus with an LVEF of 40% or less who are symptomatic should be on an MRA. MRAs are associated with the risk of hyperkalemia, and so the potassium levels should be checked within 2 to 3 days of starting an MRA, and then again at 7 days to make sure that the potassium levels are not crazy elevated. Gynecomastia or breast pain is also an associated side effect, but it's lesser with eplerenone because of the selectivity of aldosterone receptor antagonism compared to spironolactone. The combination of hydralazine and isosorbide dinitrate is recommended in African American patients with NYHA class 3 or 4 symptoms despite optimal therapy with ACE, beta blockers, and MRAs. Hydralazine and isosorbide dinitrate can also be considered in patients who are symptomatic, who cannot tolerate ACE or ARB, or if they're contraindicated, but this is a class 2A recommendation. The adverse effects of this combination includes headaches, dizziness, and GI complaints. It's hard to be adherent to this combination because of the frequency of administration. Digoxin gets a class 2A recommendation, and it can be used in patients who are symptomatic with HFrEF on optimal guideline-directed medical therapy. Low doses are recommended, and higher doses are rarely used for the management of patients with heart failure. Digoxin is associated with a number of side effects, including cardiac arrhythmias. It can cause any arrhythmia, including reentrant tachycardias, heart blocks, ectopic rhythms, GI complaints like anorexia, nausea, and vomiting, neurological complaints like visual disturbances and confusion. Usually, clinically, we check digoxin levels not to see if they are therapeutic on digoxin levels, but to check for toxicity. And toxicity can also occur with electrolyte disturbances like hypokalemia, hypomagnesemia, or hypothyroidism. Digoxin is known to react with a number of drugs, so it's important to be mindful of these interactions. Ivabradine is a new therapeutic agent, and it selectively inhibits the funny channels in the sinoatrial node. And it's important to know the mechanism of action of this drug because you can only use them in patients with a sinus rhythm. Ivabradine also gets a class 2A recommendation, and it is recommended to be used in patients who remain symptomatic after ACE inhibitor, beta blocker, and MRA with an LVEF less than 35% and a resting heart rate of 70 beats per minute. So your patient should meet all of these criteria. Ivabradine is also considered in those patients who are unable to tolerate a beta blocker, but they should also receive an ACE and an MRA, and their LVEF has to be less than 35% and a heart rate of greater than 70 beats per minute. Omega-3 polyunsaturated fatty acids get a class 2B recommendation. It is recommended in patients with NIHA class 2 to 4 symptoms with HFrEF or HFpEF to reduce mortality and cardiovascular hospitalizations. It's important to remember that only preparations with icosapentaenoic acid and docosahexaenoic acid, DHA, have been approved, and there are specific dose combinations, as you can see on the slides, which have been shown to be beneficial in patients. These recommendations are based on the GISI heart failure trial in 2008. This slide is a nice summary of the ACC/AHA guidelines and the ESC guidelines. So since we're running out of time, I quickly want to go through the class 3 recommendations. So here are the things that are associated with no benefit. Nutritional supplements, hormonal therapies other than to correct deficiencies, and statins, which are prescribed solely for heart failure, have no benefit. I want you to know that having heart failure itself predisposes you to thromboembolic events, but anticoagulation is not recommended in patients with heart failure who do not have atrial fibrillation. Now let's talk about the drugs that cause harm, and these drugs should be avoided or withdrawn whenever possible. The first one is antiarrhythmic agents. They increase mortality in heart failure, and most of them have a negative inotropic effect, and some are also associated with some pro-arrhythmic effects. The only two drugs are amiodarone and dofetilide that are not associated with increased mortality, and they have neutral effects. So they're the preferred ones to treat arrhythmias. NSAIDs inhibit renal prostaglandin synthesis. So we know that prostaglandins mediate vasodilation and inhibit sodium reabsorption. So NSAIDs can cause sodium and water retention, and we talked about it when we were talking about mechanisms of resistance of diuretics. And if your patient is on NSAIDs, it's probably wise to tell them to stop using it, because they have been associated with increased morbidity and mortality in patients with heart failure. Calcium channel blockers have myocardial depressant activity, and they have shown no clinical benefit or even worse outcomes in patients with heart failure. So the only time a calcium channel blocker can be used would be vasoselective ones, such as amlodipine, in the management of hypertension and ischemic heart disease. But generally, I feel like patients with heart failure have such low blood pressures that just getting them on the guideline directed medical therapy is difficult enough, and there is no room to decrease the blood pressure even more. So in general, calcium channel blockers should be frankly avoided in patients with HFrEF, because there are a lot of other drugs that lower blood pressure and that can be used in patients with heart failure and maybe have a mortality and morbidity benefit. Thiazolidinediones increase insulin sensitivity by activating PPAR gamma. And the peroxisome proliferator activated receptor gamma is also present in the collecting ducts of the kidney, and it regulates sodium reabsorption. So naturally, they are associated with increased heart failure events, and it's also been shown to increased heart failure events in patients who do not even have a history of clinical heart failure. So they should be avoided and are associated with harm. That is all for today. My take-home message is question everything. Question the trials you read. Question the data you come across. Question everything. I do want to mention that I do not own any of the images used in this PowerPoint presentation. All of them were taken from Google, from public resources. And the references for most of my information is just the ACCF guidelines from 2013 and 2017 update, and the ESC guidelines, which were from 2016. And that's it. I hope this was helpful, and stay awesome.